Good evening. Can we start our tutorial for this week? We'll be looking at mechanical ventilation. And we're going to be following this outline. We're going to introduce and do some definition. We'll look at characteristics of an ideal ventilator, indications for mechanical ventilation, initiation, and we'll follow the outline as provided. It's pretty long. We'll try as much as possible to see how far we can go. Now, this is a schematic diagram of a simple mechanical ventilator, how it operates. And this is from the Hamilton Medical. All right, there's an inspiratory gas goes into the inspiratory valve into the patient. And we have different processors that measures
what do you want?
Pressure and flow. Goes to the patient, and then this patient expires through the respiratory valve, and the cycle continues. So there's a schematic diagram of the simple ventilation. Please, can you mute your mic? Please, can you mute your mic? All right, so that we can all enjoy this session. Thank you. All right, so like I was saying, so we're going to start with the introduction. One of the main indications for ICU admission is ventilatory support. All right, many of our patients who are admitted for ICU are actually there for ventilatory support. The other common indication is hemodynamic support and monitoring. Even in the theater, most of our patients are mechanically ventilated in one way or the other. So generally speaking, mechanical ventilation is any method of breathing in which a mechanical device is used to either augment or to supply the entire bulk flow requirement of a patient's breathing. So a mechanical ventilator can either augment the patient's breathing or take over the patient's breathing completely. So a mechanical ventilator may be volume circled. All right, circling is actually a process of changing from inspiration to expiration. So we could have a volume circled, all right, which has to do with a preset tidal volume. And when that tidal volume is achieved, the ventilator circles from inspiration to expiration. It could be pressure circled, it could be time circled, it could also be a flow circled. Like I mentioned, it all depends on the method by which the patient, the ventilator changes from inspiration to expiration. Traditionally speaking, mechanical ventilation can be classified into the negative pressure ventilation or positive pressure ventilation. Those of us who remember the polio epidemics in the 1950s will remember the iron lung, which is an example of a negative pressure mechanical ventilator. But these days we have the positive pressure ventilator, which is commoner in our settings. And positive pressure ventilation can actually also be classified into invasive ventilation or non-invasive. And invasive ventilation has to do with the use of endotracheal tube or your tracheostomy tube. Non-invasive ventilation occurs when you do not have an endotracheal tube or tracheostomy tube in situ. Now, it's important for us to understand the characteristics of an ideal ventilator. For some of us who are residents, sometimes after our training, we may become the head of an IC unit or even the head of a hospital, and you may need to want to buy a ventilator or two. So it's important for you to understand the characteristics you're looking for. All right, like I do mnemonics a lot. So you use the word ventilate. V, a mechanical ventilator should be versatile. What we mean is that it should be able to ventilate up to a tidal volume of 1.5 liters and to a respiratory rate of as high as 60 cycles per minute, and should be able to facilitate different kinds of ventilator modes. All right, that's what we mean by versatility of a mechanical ventilator. It should be economical. It's something that you want to be able to maintain, all right, with minimal, support from outside. It should be simple, portable, and robust. Portable, a lot of times you may need to use ventilator to transport your patient. Now, the ventilator should, an IT ventilator should support nebulization of your drugs. For instance, you want to use, your nibbles, especially for patients who require some degree of, what's it called? In terms of nebulization of drugs, you can even nebulize, salbutamol or even ordinary normal saline. It should be provide the means of monitoring both inspiration and airway pressure, because you don't want to have airway trauma or barotrauma. It should last long, because you don't want to buy a ventilator that you want to change every 3 months or every 6 months. A ventilator with an alarm system is a killer. So you want to have a ventilator with alarm system. All right, different kinds of things can set up the alarm, disconnect alarms, airway pressure alarm, and all that. And it should be able to easy to clean and sterilize. All right, so these are some of the things I put together that would define an ideal ventilator. So the indications for mechanical ventilation, the primary indication is respiratory failure. All right, that is the primary subjective indication for mechanical ventilation. All right, and note that before you put a patient on ventilator, you should establish the indication for the respiratory support, and you must also establish that the underlying condition for which the patient has gone into respiratory failure is reversible, or you may have a patient who is ventilator dependent and weaning may become impossible. We have other objective indications for mechanical ventilation: respiratory rate less than 5 cycles per minute or greater than 35 cycles per minute, a tidal volume of less than 5 ml per kg, vital capacity less than 15 ml per kg. Please, can we mute our mic so that we can have some good time here, please? As you are joining, mute your mics, please. All right, arterial blood gas values is very important. A PO2 of less than 8 kilopascal or less than 60 millimeters of mercury, or a PaCO2 of greater than 8 kilopascal or greater than 60 millimeters of mercury. These are objective indications for initiating mechanical ventilation. All right, I mentioned that the subjective indication, the primary indication for mechanical ventilation is respiratory failure, and it's good for us to understand what we're talking about. So respiratory failure is commonly defined as the inability of a patient to maintain normal arterial blood gases. Inability of a patient to maintain a normal arterial blood gases. All right, categorically, it can also be defined as an arterial PaO2 at sea level when a patient is breathing air that is below 60 millimeters of mercury without evidence of intracardiac shunting. There are 2 types, sometimes we say 3 types of respiratory failure. We have type 1, which is hypoxemia, type 2, hypercapnia. We can have a mixed types of respiratory failure when we have a type 3, when you have hypoxemia and hypercapnia coexisting. Respiratory failure could also be acute or chronic. So any patient in respiratory failure requires some form of ventilatory support. Oh my God, there are so many disturbances. Please help us. All right, modes of ventilation, there are two, basically, major broad modes of ventilation. We have the assisted mechanical ventilation or controlled mechanical ventilation. Suffice to say here that we're looking more into mechanical ventilation in the ICU setting. And the commonest mode that is used in ICU is the assisted mechanical ventilation. All right, the idea is that it is designed to work with the patient's own respiratory effort. All right, the patient continue to make some form of respiratory effort throughout the support. In this mode, patient's inspiratory effort, no matter how little, is detected, and this is what triggers the mechanical device to boost the inspiratory breath. All right, control mechanical ventilation, sometimes we use commonly in the operating room. All right, in control mechanical ventilation, it can actually either be volume controlled or pressure controlled. In this mode of ventilation, the ventilator delivers a preset tidal volume, all right, at a specified respiratory rate. And this ventilatory delivery is irrespective of the patient's respiratory effort. A lot of times the patient is paralyzed or heavily sedated. In control mechanical ventilation, as you can see on the right side of the screen, all right, there is no patient's inspiratory effort in this mode of ventilation. All right, so in between the ventilator deliver breaths. At this point, the inspiratory valve is closed, so the patient can't take in any breath. The peak inspiratory pressure developed, therefore depends on the patient's lung compliance and airway resistance. So for patients whose lungs are not compliant, you can have a very high peak inspiratory pressure. All right, or patients with restrictive or reversible airway obstruction, you will realize that the ventilator will require greater pressure in order to deliver the preset tidal volume. There are some indications in ICU. Like I said, the common mode of ventilation is the assist mode, but there are some indications for control mechanical ventilatory control in the ICU. This includes patients with tetanus, or patients that have intractable seizures, patients with cross-chest injury, or patients who, despite all that you have done, patient is still fighting the ventilator or walking on the ventilator, as the case may be. Some of the disadvantages of controlled mechanical ventilation is that you can have asynchrony between the patient and the ventilator setting. And because the patient will require high peak inspiratory pressure, they are prone to barotrauma. All right, and this will also lead to hemodynamic compromise from reduced venous return due to increased intrathoracic pressure. You can have ventilation perfusion mismatch. And a lot of times, because the patient is not taking part of the breathing or the ventilatory exercise, you can have muscle atrophy, which could actually lead to ventilator dependence. And that is why commonly for patients who will require mechanical ventilation for a period of time, controlled mechanical ventilation is discouraged. All right, in pressure controlled, what we mentioned before is volume control. Like I mentioned, controlled mechanical ventilation can actually be volume control, where the ventilator delivers a preset tidal volume. In pressure control, the ventilator delivers a pressure limited time circuit breaths. Here, it is the inspiratory pressure that is preset. All right, And as if we have time, we're going to look at some ventilator waveforms. The ventilator waveform in pressure control gives us a decelerating flow pattern. Here, the inspiratory pressure is set, and whatever happens is that the pressure that the ventilator generates cannot be above the preset. And one of the advantages of this is that it reduces the risk of barotrauma. The peak airway pressure over alveolar pressure is controlled, all right, but the tidal volume, the minute ventilation, and alveolar pressure depends on the patient's non-compliance, the respiratory rate set, and the inspiratory-expiratory ratio, the IE ratio. All right, the advantages of pressure-controlled ventilation is that it requires less peak airway pressure. So like I mentioned, reduces the risk of barotrauma or hemodynamic disturbances. All right, there's even distribution of gases in the alveoli, and the compensation for loss of ventilation is better because the inspiratory pressure is what is preset. Like the control mechanical ventilation generally, this mode of ventilation is also prone to patient ventilator asynchrony. And in case of reduced lung compliance or increased airway resistance, tidal volume may be reduced. You may not be able to achieve your desired tidal volume. And because of this, you can have ventilation perfusion mismatch. So quickly, the difference between volume controlled mechanical ventilation and pressure controlled mechanical ventilation is the preset parameter. In volume control, the tidal volume, for instance, you want to give the pressure 500 mils of air, you set your tidal volume at that. So what you're telling the ventilator is that no matter what you meet on the way, no matter the lung compliance, no matter the airway resistance, I want this patient to have 500 mils. So that is why this ventilator will do whatever it is, generate enough pressure to deliver the 500 mils that has been preset. And that's why they are prone to barotrauma. In pressure controlled, the inspiratory pressure is limited. So no matter the lung compliance, the airway resistance that the ventilator may meet on the way is not going to go above that. Maybe you set it at 30 centimeters of water pressure. So that will reduce the tidal volume when the patient has reduced lung compliance and what have you. The common mode of ventilation we use is the assist control or the assist mechanical control. We call it the AC mode. This is what we fancy in ICU because here, what the ventilator does is to augment or to assist patients initiated breath. All right. But if the patient does not make any breath at all right, maybe there's a central apnea or patient is still under the influence of neuromuscular blocker or the patient has neuromuscular disorders, the ventilator will still deliver a preset tidal volume at a preset respiratory rate. But in all of it, the ventilator will wait. You can see on the graph on your right side, below the baseline, you'll see the patient trying to take some breath. So the patient initiates the breath and the ventilator assists to augment the breath to have desired tidal volume. All right, the mandatory mechanical breath, there's what we call the mandatory mechanical breath. Whether the patient is initiating any breath or not, the ventilator gives a mandatory breath. All right, this can either be patient triggered or time triggered. If respiratory rate of the patient is less than the preset ventilator, the preset rate on the ventilator, the machine will assist in a controlled manner. Advantages is that it reduces patient's work of breathing because the patient initiates breath and the ventilator takes it over from there to assist the ventilator, all right, to assist the patient. It enhances better patient ventilator synchrony because they're working together, the ventilator, the mandatory breath, and the patient's inspiratory breath are working together. As a result, it leads to less VQ mismatching. And because the patient is taking part of the breathing exercise throughout the breathing cycle, it prevents disuse atrophy, and it helps maintain respiratory muscle integrity. Because the ventilator is assisting, you can have what we call alveolar hyperventilation. And this has been taken care of by newer modes of assist mechanical ventilation. We can have high intrinsic PEEP in obstructed patient because you can have breath stacking, and there is not enough time for air to be fully removed from the alveoli during expiration. And this may lead to increased mean airway pressure, which can lead to hemodynamic compromise. There are different modes under assist mechanical ventilation. We have the IMV, the intermittent mandatory ventilation. We have the SIMV, the synchronized intermittent mandatory ventilation, the mandatory minute ventilation, and all that. As we go on, we would touch on each of these different modes under assist mechanical ventilation. All right, so the first thing we're going to look at, I want you to always pay attention on the right side of the slide, because it gives us a dramatic representation of whatever we're talking about. All right, in intermittent mandatory ventilation, the ventilator delivers a preset, all right, preset number of times cycled mandatory breaths, all right, and allows the patient to breathe spontaneously in between. All right, you can see it here that these dotted ones are patient's breath, all right, respiratory breath. These are patient respiratory breath. So the ventilator delivers a time cycled mandatory breaths, and it stops. It allows the patient to take some breaths on his or her own. All right. In this mode of ventilation, you require less sedation because you want the patient to be able to breathe in between the mandatory ventilatory preset values that you have set. All right. It leads to lesser VQ mismatch, lesser hemodynamic compromise. Like I said, breath stacking occurs here because there's pilation of breaths, both from the patient and from the mechanical ventilator. You can have increased lung volume, so you can have volume trauma, and you can have barotrauma. In synchronized intermittent ventilation, what happens here is that the ventilator, look at it here, unlike the previous one that we saw, where, all right, there's no synchrony, or here, there's synchrony. The patient's breath and the machine breath are synchronized into one. So you have, this is patient's breath, spontaneous breath, and it synchronizes with the patient's breath. So you can have your desired tidal volume. The patient breathes, and there's this, what we call synchronization window. This is the time interval just prior to time triggering. All right, the patient triggers the ventilator. This is what we call the synchronization window, the time between the patient's spontaneous breath and when the ventilator detects it and synchronizes it. One of the most important advantage of SIMV mode is that it prevents breath stacking, which is very important, all right, because the patient's breath and the machine breath is taken as a unit, as one. So there's no pilation of different breaths, therefore avoiding what we know as breath stacking. In between mandatory breaths, patient is allowed to take spontaneous. You can see here, patient is taking some spontaneous breath, and it gets to a point that it triggers the ventilator, and they now produce your desired tidal volume. Advantages of SIMV include because the patient is breathing on his own in between mandatory breaths, right? It maintains respiratory muscle strength throughout, thereby avoiding disuse atrophy, reduces VQ mismatch, reduces mean airway pressure, and actually it facilitates weaning of the ventilator because throughout the patient is taking some breath. Disadvantages include the desire to wean quickly, all right, and this can lead to failure to wean. You know, you see that the patient is taking some breath. I say, oh, let me wean the patient off, and when you wean the patient off too quickly, all right, you can have the increased work of spontaneous breathing, and patient may fatigue, and you will have what we know as failure to wean. So it's very important for you to clinically observe your patient before you attempt weaning, especially with SIMV mode. All right, PEEP here, I decided to put PEEP here. We may have to look at it as we go on, but let's leave PEEP out of it now, and CPAP, we can come back to it later. So the mandatory minute ventilation is actually similar to intermittent mandatory ventilation, except that the minimum minute volume is what is set here rather than the respiratory rate. All right, the minimum minute volume, all right, is calculated and is fed into the ventilator instead of the respiratory rate. You don't forget that minute volume is respiratory rate times tidal volume. So this is suitable for patients that have variable respiratory drive. They are hyperventilating 1 minute, they are hypoventilating the second minute. So instead of just presetting respiratory rate, you want the minute volume to be delivered at all times, right? This is what we mean by mandatory minute ventilation. All right, I know that some people are just joining us. Please, can you mute your mics, please?
Okay, but I think
All right. Easy, please mute your mic. Thank you. All right, the other one is the pressure support ventilation, which can actually also be a winning mode. As we go on, we look at it. The pressure support ventilation supports spontaneous breathing of patients. Each inspiratory effort that the patient is making is augmented by the ventilator at a preset level of inspiratory pressure. Most of the time, we use a patient-triggered flow circle pressure control mode. All right, what it does is that it applies, all right, Yusuf, you are raising your hand.
Sorry, sir, it's a mistake. Sorry.
Okay.
Yes, sir. Sorry. Thank you, sir.
All right, so in pressure support ventilation, pressure is applied to during the patient airway during spontaneous breathing. And like I mentioned before, it can actually be used with any mode of ventilation, the pressure support. What happens is that you apply pressure to help the patient overcome resistance or dead space from your, whatever it is, from your tubings, your tracheal tubes, even from the apparatus dead space from the mechanical ventilatory device. So it helps to overcome that so that the patient doesn't have to develop pressure, right, to overcome some of this resistance. All right, thank you. Let me tell them, kindly mute yourself. Thank you. Okay, where are we? Disadvantages of PSV, pressure support ventilation, includes, you can be sure that it's not suitable for patients with central apnea, all right, because it's not going to initiate the breath for the ventilator. It's not giving any mandatory breath. It's only assisting patient inspiratory pressure at all time, all right? And because it's supporting the pressure, you can have highway pressure with compromise. Now, this is some of the things we're talking about on the right side. This is SIMV volume control with pressure support. SIMV volume control with pressure support. All right. So what the ventilator does is to just add some pressure to overcome anatomical and apparatus dead space. Yes, some ventilators have, I've worked with some ventilators, and in your setting, you need to be familiar with the kind of modes that are available in your ventilator. Well, we have what we call the adaptive support ventilation. And I remember that there was this ventilator I worked with in Shep, Port Harcourt those days. They have this mode, beautiful modes, adaptive support ventilation. What it does is that you feed patients parameter, like the weight of the patient, 75 kg, and you calculate the percentage minute volume you want to deliver, and you enter these parameters into the ventilator. And once you do that, the ventilator selects and provides the required frequency, the respiratory time, the IE ratio, and sets pressure limit for mandatory and spontaneous breath. It's beautiful. The clinician does not have to be playing with the ventilator and all that. Once you enter the patient's body weight and the percentage minute volume you want to deliver to the patient, the ventilator just calculates and selects the appropriate frequency, the respiratory time, and all that. All right, this ventilator mode can either be time or patient triggered. It's beautiful when you have this mode. It saves you a lot of hassles. That's what we call the proportional assisted ventilation. All right, it's actually a spontaneous breathing mode. And what it does is that it helps the patient in proportion to the patient's effort. All right, if the patient is making 25% of the inspiratory effort, all right, the ventilator will provide 75%. All right, if the patient is making 75% or 50%, what the ventilator does is that it assists the patient based on the proportion of the patient's effort. All right. Now, the beautiful thing about it that it says to overcome 80% of airway elastance and airflow resistance. So, for instance, if the patient is breathing and it encounters some airway resistance, the ventilator sees it and helps the patient to overcome the resistance. Okay, thank you. I've been told I can mute people who are unmuted. All right. So in this mode, it instantaneously measures flow and volume that the patient is pulling and calculates the compliance and resistance of the respiratory system. Actually, these are smart mode of ventilation. All right. For indications, the patient must have some breath. All right. It must have inter-respiratory drive, and there must not be any muscular dysfunction or disorder before you can use this. Okay, volume assured pressure support ventilation. All right, what this does is that it incorporates inspiratory pressure support ventilation and conventional volume assisted, all right, mode. What it does is that the desired tidal volume and pressure support are preset. Once the patient triggers this mode of ventilation, the desired pressure support level is achieved as soon as possible, all right, quickly, and the delivered volume is compared with the preset tidal volume, all right? Then once you do that, if the volume delivered by the ventilator is more than the preset tidal volume, all right, you have what we call pressure support breath. So you're not going to have additional tidal volume. What you have is pressure support. But if the volume delivered is less than the preset tidal volume, the ventilator switches to volume limited, all right, which results in longer expiratory time until the preset tidal volume is delivered. So at all times, the tidal volume that is set for the patient is assured, and that's what we mean by volume assured pressure support mode. Yes, I've worked with these ventilators that have this mode. This is also another beautiful mode. The ventilator in King Faisal Hospital in Kigali, Rwanda has this, and beautiful. What it does is this. The purpose of this that it helps you to keep your peak inspiratory pressure to the lowest level, that is possible. All right. It's giving you volume support while keeping your peak inspiratory pressure to the lowest level. How do you do that? It alters the peak and inspiratory time in response to changing airway compliance or characteristics. Sometimes your patient's airway characteristics varies. All right. For instance, they could have accumulation of secretions. You could have all sorts of things that could cause some variation in airway compliance. Maybe the patient develops ventilated associated pneumonia in the course of being ventilated. All right. So what pressure regulated volume control does is that it helps you to alter your peak and inspiratory time so that you don't have excessive peak inspiratory pressure. All right. If there's decreased compliance or airway resistance, what it does is that instead of increasing peak inspiratory pressure, it increases inspiratory time. It gives you more time, all right, so that your tidal volume will be delivered. At constant flow, your peak inspiratory pressure increases with increased airflow resistance. Why there's a decreased flow during reduction in airway resistance. All right, to compensate for low flow due to whatever, maybe increased airway resistance or poor lung compliance, the inspiration time is prolonged. The patient takes longer time during inspiration. We have the APROV, the airway pressure release ventilation. All right, this is similar to CPAP, continuous pressure airway, continuous pressure. All right, as patient can breathe spontaneously. In this mode, the airway pressure is maintained at moderately high level. All right, and increased pressure ensures alveolar recruitment. Actually, this is a recruitment maneuver. All right, and oxygenation. What it does is that it causes brief deflation of your alveoli with CO2 excretion without causing alveoli collapse. It is actually indicated as an alternative to volume cycle ventilation for patients with reduced lung compliance, especially in ARDS patients or patients that have increased chances of barotrauma because of the lungs, the alveoli that have been damaged. Inverse ratio ventilation, we'll come back to it. Let me just proceed because tracheal gas insufflation, these are things we will come back to as we go on. Let me quickly talk about this new mode of ventilation known as neurally adjusted ventilatory assist mode. All right. Now, it's important for us to understand how this operates. All other modes of ventilation we've talked about actually, follow the conventional pneumatic signals. They either follow flow, volume, or airway pressure changes to drive and control the operation of the ventilator. But in neurally adjusted ventilatory assist, I don't know, kind are they doing? How do I mute you now? You're making life difficult. I'm getting distracted. Okay. Mute. Okay. I think I succeeded now. Okay. Is Dr. Bodilawa here? Boss, how are you, sir? Is this the Bodilawa I know?
Good evening, sir.
Ogami, sir, is you I'm seeing here?
Yeah, thank you.
I'm loyal, sir.
Okay, all the best. Enjoying
Thank
the.
you, Ekbele, sir.
Yeah.
All right, let's go on. Sorry for that. You know, you must give honor to whom honor is due. Okay, so neurally adjusted ventilatory assist mode, like I mentioned, in all the other modes, all right, the ventilator makes use of conventional signals like the flow, all right, the volume, the tidal volume, the airway pressure, even time. But in neurally adjusted ventilatory assist mode, all right, what it does is that it uses the electrical activity of the diaphragm, all right, to offer ventilatory assistance in proportion to the patient's effort. Don't forget that the respiratory center sends signals to the diaphragm, and that's what causes the ventilation mechanisms that you see. But in this mode, you pass a dedicated gastric feeding tube, all right, on the diaphragm. So what it does is that it captures the electric signal from the patient's respiratory center, all right, which normally activates the diaphragm. And this is how it helps to assist the patient, you know, to provide ventilatory support. In all of this, one of the beauty of it is that it allows the patient to retain full control of his or her breathing, because whatever support that the ventilator is given is secondary to the signal that it picks, all right, from the diaphragm, because we have a catheter, a feeding tube. I'll show you very soon in the next slide. One of the modes that improves patient ventilator synchrony is NAVA mode. It reduces the risk of assistance, all right, and which makes it an attractive alternative for patients who experience clinically significant asynchrony when you are using pressure support ventilation. Now, the next slide shows us how NAVA works. Now, you pass an NG tube, all right, and so the patient with an electrode, this is the diaphragm, all right, and this is connected to a microprocessor. This is the esophageal catheter that goes, all right, with electrodes. What it does is that it picks the signals that the diaphragm is receiving from the higher center, all right. What it does is that it now processes it from the electrode to your microprocessor on the ventilator, processes it, and this is what determines the kind of support that the ventilator will give to the patient. So it's known as neurally adjusted ventilatory assist mode, all right? This is your esophageal signal that is being picked, all right, from the dedicated, what's it called, the catheter that you have passed, and it passes it and it determines what ventilatory support you give the patient. Somebody raise his hand, any issue? Or is it a mistake again? Okay, I think it's a mistake. Let's go. We have a lot to talk about, guys. Okay. Okay, so now how do you initiate mechanical ventilation? Number one is that you need to ensure, all right, the indication for the ventilatory support in the first place is reversible. All right, why does this patient need a mechanical ventilator or ventilatory support? You know, you need to establish the indication for the ventilatory support. Number two, which we often do not do, but which is important for medical legal reason, always ensure you obtain consent from the patient if he is conscious. Hey, the way you are breathing is not looking good. We may need to assist you, all right? And the patient understands the need for the ventilation. And if the patient is not conscious, you need to obtain consent from the relatives. I wonder how many of us do this. Before you put a patient on a ventilator, you must obtain your baseline arterial blood gases, because it will determine the settings you will feed into the ventilator. Ensure adequate supply of gases and oxygen, and proper working of the ventilator. In places where power is a problem, you want to ensure that if the ventilator is power dependent, that is connected to electric source. And we had an issue before some time ago, I don't want to mention the center, where somebody put a patient on ventilator, but there was no power. So the patient, we thought the patient was on ventilator, but the patient wasn't being assisted at all. And there's this other case where there was a particular bed where the patient normally dies. The patient dies around 4 a.m. every day. And even no matter the condition of the patient just dies around 4 a.m., 4:30. And until they discovered that one of the cleaners would normally go to that place, unplug the ventilator, and plugs his phone to charge his phone. So before you put a patient on ventilator, ensure proper working and proper supply of gases, and especially oxygen. Then you must decide what kind of mode of ventilation. Am I going to assist this patient, or am I going to take over the patient's breathing completely? Then you want to enter your ventilator setting. And we're going to come to that as we go on. Initially, you want to give 100% oxygen, FiO2 and you gradually reduce, in the course of 1 to 4 hours to not more than 0.6, because high flow oxygen or high concentration of oxygen for a long period of time will predispose the patient to oxygen toxicity. Initially, minimum PEEP of 5 centimeters of water. All right, this is what we call physiological PEEP. All right, you start with that, and sometimes you may want to do therapeutic PEEP, which is PEEP between 10 to 20 centimeters of water. Tidal volume between 7 to 10, except you are doing low tidal volume ventilation where you can have 6 to 8 ml per kg. Initial expiratory pressure should be at 20 centimeters of water, and for adults, frequency should be between 10 to 12 cycles per minute, and your pressure support or assist spontaneous breathing should be around 20 centimeters of water. The normal aeration is between 1 to 2, and your flow trigger should be at 2 liters per minute, and pressure trigger to between 1 to -3 centimeters of water. These are your initial ventilator setting that you want to enter. There's what we call smart ventilation. SMART is an acronym, and we're going to SMART. S talks about setting, M talks about the mode, A talks about adjuvants, R talks about release or weaning of the patient from ventilator, and T, you need to do troubleshooting of your ventilator, especially when you have some issues. So setting, like I mentioned before, you want to determine the respiratory rate that you want to give the patient. All right, tidal volume is calculated, and you want to give it, all tidal volume should be expressed as mils per kg of the ideal body weight. All right, for most patients, you want to, as well for low volume ventilation, you want to give 6 to 8 mil. For patients with acute respiratory distress syndrome, because of the friable lungs, sometimes you want to go as low as 4 to 6 mil. In my practice, I don't usually go below 6 mil, no matter what. But patients with restrictive lung volume may need a tidal volume of between 5 to 8 mil per kg. You want to set adequate flow rate. Usually, the usual setting is between 40 to 100 liters per minute. But don't forget that sometimes the peak flow rate is the maximum flow that is delivered by the patient during inspiration, and 40 to 60 liters per minute may be sufficient. All right, the flow rate. Don't forget that an insufficient peak flow rate may predispose the patient to what's it called, patient ventilator asynchrony, and you can actually have dyspnea, difficulty with breathing with insufficient peak flow rate. All right, inspiratory time normally is I ratio inspiration, expiratory time is between 1 to 2. Don't forget that if the expiratory time is too short, you have breath stacking because you don't have enough time for the expired air to leave the lungs. And sometimes you may want to have what we call inverse ratio ventilation, where you want to increase the respiratory time above your expiratory time, especially in case of difficult oxygenation or difficult hypoxemia. Like I wrote, I said, occasionally longer expiratory time is desired to allow more time for the lungs to be oxygenated. FiO2, I mentioned this before, make sure you start with 100% or one FiO2, but you must, and that's why serial ABG is important. I tell my doctors who work with me here, I do a baseline ABG before I put the patient on ventilator, and 1 to 2 hours after the patient is on ventilator, I want to do another ABG because I want to reduce my FiO2 from 1 or 100% I started with, and also I may be able to change some settings based on my ABG values. But the rule of the thumb is that your FiO2 should only be as high as is necessary to keep your PaO2 in the desired range of between 75 to 97 millimeters of mercury. Set your pressure limit because this protects against barotrauma, and don't exceed, most of the time we do not want to exceed between 30 to 35 centimeters of water. A higher pressure may be generated. If you have a higher pressure being generated, you want to troubleshoot and rule out any obstruction, which could be due to a small little thing like secretion or mucus plugging, or patient may actually be coughing or biting on your endotracheal tube. All right, so you want to find out, and that's why troubleshooting comes in. Your trigger, all right, most of the times, what triggers the ventilator to give assisted breath will either be pressure or flow triggered, all right? But a lot of times we use flow trigger, which is better for patients who are breathing spontaneously, because it kind of reduces the work of breathing. All right, in the older machines, presently in our ICU, we don't have PSI, but actually PSI was used to prevent atelectasis. All right, but the associated barotrauma and alveolar rupture have caused it to fall into disrepute. But it's important for the sake of academic purposes that you understand what a PSI is. A ventilator PSI is actually deep breath, which is usually greater than the normal tidal volume. It's about 1.5 to 2 times greater than tidal volume. All right, it is programmed to deliver higher tidal volume to help with oxygenation. A lot of times, usually between size actually incorporated in those machines, and it occurs between 4 to 8 times per hour. All right, to ensure that you have adequate oxygenation and prevent alveoli collapse. The M is the mode I mentioned before. You need to select the mode, look at the advantages and the disadvantages of your mode, and you select it appropriately. All right, adjuvants. I coined this word Philippe. All right, the adjuvants actually, different types of things that can be used to aid your ventilatory goals. All right, before you put a patient on ventilator, you have goals that you want to achieve. And we're going to come to that as we go on. I talk a little more about it in the slides as we go on. But just know that Philippe is an acronym. P stands for PEEP, A stands for high flow, all right? I stands for inhaled nitric oxide or independent lung ventilation. L stands for low volume, all right? I stands for inverse ratio ventilation. P stands for prone positioning, and E stands for ECMO. All right, I like asking my students this question: what are the ways of optimizing oxygenation without increasing FiO2? If your patient is desaturating or you do not have adequate oxygenation, a lot of us will just increase FiO2. No, don't do that. All right, high FiO2 is associated with oxygen toxicity and all that. All right. So there are other maneuvers that we can do to improve our oxygenation without necessarily increasing FiO2. We'll come into that as we go on. All right. And let me just talk about prone ventilation, and we'll look at how we'll look at the adjuvants. Prone ventilation is actually a rescue type of adjuvant, which is reserved for what we call, somebody's talking now. Let me see who this person is. Let me quickly mute the person. Okay, Chuku. Okay. So prone ventilation is reserved as a rescue option for severe acute respiratory distress syndrome. Don't forget that it requires adequate sedation and muscle paralysis. You're going to put the patient prone, face down, and you require regular arterial blood gas analysis, all right, to assess your degree of oxygenation. I like mnemonics a lot by now, you know me. Indications for prone ventilation includes prone, all right. P is PEEP. When you are given PEEP greater than 7, all right, when a patient requires PEEP greater than 7, when the patient is in respiratory failure, all right, with the oxygen index, oxygenation index between 200 and 300. When the patient has failed, oxygenation has failed, and when you have early onset ARDS, all right, you know, occurring in less than 48 hours, you want to give the patient prone. Okay, ECMO, all right, we'll talk about that as we go on. So weaning, the R stands for release or weaning, all right? When do you wean the patient off ventilator? And I coined the word when the patient is no longer a ghost, all right? When the patient is no longer a ghost. You know, G means that the patient GCS has improved significantly, all right? And I target a GCS of 13 or 11T over 15. Patient is hemodynamically stable. Do not attempt winning a patient who is on inotrope. Let me repeat this. No matter the ABG parameters, if the patient is still on inotrope or requiring inotropic support to maintain MAP above 65, do not start winning. It will fail. All right. O is when oxygenation has improved. Your respiratory rate is less than 35 cycles per minute. You are giving FiO2 less than 0.5, and you are achieving SpO2 greater than 92%, and you are requiring less than less than 10 centimeters of water of PEEP. Your patient has passed spontaneous breathing trial, all right? When your rapid spontaneous breathing index or Tobi's index is less than 100. Tobi's index is when you're using respiratory rate over tidal volume. A Tobi's index of less than 100 frequency per minute per liter, all right? You know, the patient has passed your spontaneous breathing trial. And then when there's no more fever, temperature is now less than 37.5 degrees Celsius. Sometimes we have what we call failure to wean. Every attempt at weaning the patient. And failure to wean can either mean failure to release the patient off ventilator or failure to even extubate, because weaning is not just getting the patient off ventilator, you must be able to also extubate this patient or decannulate the patient if you are having the tracheostomy. So we have reversible causes, and it's important that you look at it. Why am I having difficulty in weaning the patient off ventilator? And we have what we call the wheeze snort. Is the patient wheezing? If the patient is wheezing, so there be some airway obstruction. You can nebulize the patient. You can suction to ensure that there are no secretions. Does the patient have heart disease, left ventricular hypertrophy or left ventricular failure? Electrolyte derailment, always ensure that your electrolytes are corrected and within normal limit. Sometimes anxiety, and in my practice, I've noticed that when I've ruled out all the other reversible causes and my patient is still finding it difficult to wean, I just give some anxiolytics, some low dose midazolam to calm them down, and you'll be surprised how you are able to wean the patient off. Nutritional insufficiency, which can be under or over nutrition, can be a cause of reversible weaning. Sepsis, as the patient develops ventilator-associated pneumonia, you're going to look at your inflammatory markers, sepsis marker, your CROP, your procalcitonin. Opioids, patients with prolonged opioid use, you may need to reverse opioids use with naloxone. And right, if you're having difficulty in weaning your patient off ventilator. Patients with thyroid disease, hypo or hyperthyroid, thyroid patients may have some difficulty. And when you do your T4, T3 over T4 ratio, and you're able to manage the thyroid insufficiency, you'll discover that your patient, you will be able to wean your patient successfully. You need to troubleshoot. It's important for you to know how to troubleshoot your ventilator. In troubleshooting your ventilator, you want to first of all assess the patient's need for resuscitation. Does this patient require resuscitation? There's a problem. You know, a patient who is being ventilated, there's some problems either from the patient parameters or from your monitors. You want to first of all do assessment. Does this patient require urgent resuscitation, fluid, or whatever it is? Do you want to assess the patient's airway and all that? In assessing the patient's airway, follow this mnemonic we call DOPE, all right, DOPE. You want to check the endotracheal tube, is it displaced? It could have gone endobronchial, or you have accidentally extubated the patient. Is your tube kinked, or is the patient biting on the tube? Most of the times, I always have like oropharyngeal airway in all my intubated patients. Is there a pneumothorax, all right, iatrogenic, or the patient came with pneumothorax, or is the patient in the esophagus? So always dope your patient's airway in assessment. If your monitor is showing you high airway pressure, you want to look out for the causes, all right? Is there an inappropriate setting on the ventilator? Maybe you have given the patient excessive tidal volume, or there's excessive flow or low inspiratory time. All this may lead to increased airway pressure. All this may be due to bronchospasm. You could have reduced chest or lung compliance. You want to just troubleshoot and see how you can regulate what is happening. A patient who develops hypotension while on mechanical ventilator, you want to look at what are the causes of hypotension here. Is the patient hypovolemic? Is the patient, has the patient developed pneumothorax? All right. And a lot of times, if the hypotension is due to hypovolemia or drug-induced vasodilatation, you may want to quickly give the fluid resuscitation with 10 ml per kg of crystalloids, as the case may be, and you'll just find out that you're able to remedy the situation. Patients who develop PVA, patient ventilator asynchrony, you want to look at what is causing this, and most of the times it's due to inability or failure of the patient to trigger the ventilator appropriately, or there's increased flow. You want to check what is happening, and a lot of times you may want to change your mode to neurally adjusted ventilatory assist mode, which is better for this patient. A patient on ventilator may desaturate. All right, when this happens, you want to troubleshoot. Why is my patient desaturated? You want to look at the causes. All right, is there's a case of, I remember some years ago when during nursing procedure, Tony, a patient was accidentally extubated. And instead of the nurse calling attention, he just pushed the tube back. Obviously, the patient desaturated, arrested. All right. So why is this patient desaturating under my care? All right. No matter what the cause may be, always increase the FiO2 to 100% while you are looking for the cause of the desaturation. A quick bedside lung ultrasound can be helpful to rule out pneumothorax and other causes of desaturation. If you have done all, you can't find out the cause. A quick bedside chest X-ray is indicated in this patient. Now, leaks can occur around the cuff or your endotracheal tube or your tracheostomy tube. There could be leaks around the circuits and all that. You want to ensure that there are no leaks. How do you know there are leaks? When you have very low airway pressure and chest is not rising adequately and all that. You want to find out and check all your connections to be sure that there are no leaks. All right, so this is a diagram to show you how to proceed. All right, when a patient is on ventilator and there's an acute respiratory deterioration, check the peak inspiratory pressure. All right, this is important. If the peak inspiratory pressure is low, you want to check for air leak. Is there any leak anywhere in the circuit? Starting from your endotracheal tube, your cuff, your tracheostomy tube, you want to check all the connectors, all right? Your breathing circuit. You want to ensure that there are no leak, or is the patient hyperventilated, not having enough time for pressure to build? If the peak inspiratory pressure is increased, you want to look at the plateau pressure. Plateau pressure is the peak inspiratory pressure minus the peak expiratory pressure. All right. If there's no change in your plateau pressure, you look at what is causing airway obstruction here. As this patient aspirated, is there bronchospasm? Are there secretions? Is there obstruction in the endotracheal tube? But if the plateau pressure is increased, all right, that is, you have more inspiratory than expiratory pressure, you want to look at abdominal distension that is causing splitting of the diaphragm, asynchronized breathing, airway collapse. Patient has developed auto-PEEP, pneumothorax, and all that. Now, if there's no change in your peak inspiratory pressure, all right, maybe the patient has thrown an embolus, all right, that is blocking a major pulmonary vessel, or you look for extrathoracic causes of the respiratory deterioration. So you must learn how to troubleshoot your ventilator when your patient is on it. Okay, I think, okay, this is what I was talking about, how to improve oxygenation. Our time is up. We spent more than 1 hour already. How to improve oxygenation without increasing your FiO2. This is important. Philippe, don't forget, increase PEEP. You want to do high flow ventilation, you can give as high as 60, all right, or you can give as high as 80. You want to do inverse ratio ventilation, low tidal volume with high respiratory rate, probe ventilation, and you give ECMO. All right. How do you win of the ventilator? We have different types, especially the modern ventilator has different winning modes. All right. But normally we do what we call spontaneous breathing trials. And before you commence spontaneous breathing trials, there's what we call sedation vacation. Here in ICU, we always do sedation vacation around 4 to 5 a.m. so that when I come for around 8, it's better you will be able to do your spontaneous breathing trial. So sedation vacation for 2 hours, then you withdraw your machine support and you connect your patient to a T-piece or a CPAP circuit, all right? And you can do that for 30 minutes. You wash, you connect back, and if the patient is doing well, you increase it gradually, all right? Now, what this does is that it allows the patient to gradually take over the work of breathing while you are shortening the rest periods with the backup of the ventilator. Another common one is what we do the pressure support weaning. All right, in all of this, you take off ventilatory breaths, all right, and you allow the patient to initiate all breaths, but you are providing pressure support so that it can help to overcome any difficulty or any resistance from your tubes or whatever it is. All right. What you do is that you continue to reduce the amount of pressure you are providing for the patient so that the patient becomes more responsible. The patient takes more responsibility for his ventilation. Once you are able to give your pressure support to between 5 to 10 above PEEP, you cannot do a trial of TPs that we mentioned before. All right, I'm not going to go into that today, non-invasive ventilation. And let me see if I can. Oh, ventilator waveforms. This is important because from your ventilator waveforms, you may be able to troubleshoot your ventilator. Okay, let me see. Now, how to use graphs for diagnosis of disease states. All right, now let me quickly state here, ventilator waveforms are actually two. We have the scalar waveforms and the loop waveforms. The scalar waveforms is when you are plotting either pressure or flow or volume versus time. Time is always on the s-axis, all right? So you're plotting pressure, volume, flow against time. In loop, you are plotting each of the parameters against themselves, pressure versus flow, time versus volume, all right? And that is the traditional way to do it. Okay, so time up. This is what I'm talking about, the scalar. This is a plot of pressure, volume, flow against time. Time is always on the s-axis, while loop waveform is when you plot pressure, volume, flow against each other. All right, and there are different types, all right, of scalar waveforms. We have the square waveform, ascending ramp, descending ramp. We don't have time to talk about all this, but I'm sure those of us who have worked with ventilators would have seen different waveforms on our ventilator. I want to encourage you, when you get to work on Monday or something, or you're working with your ventilator, just look at the different waveforms and look at the plot. Anytime you see time on the s-axis, is a scalar waveform, all right? And it helps. There are different types that you can use. Most of the time we use the decelerative flow form, especially for pressure control ventilation, is the decelerative flow pattern that is normally used. Okay. All right. This is the loop waveform I told you about. All right. So the pressure volume loop, for the loops waveform, the volume is on the y-axis, while the pressure is on the s-axis. All right. The inspiratory curve is actually upward, while the inspiratory curve is downward. And the bottom is actually, I said, at PEEP. So if your PEEP is 0, all right, it will be at 0 this way here. The reason why this is important, it helps you. You can make some diagnosis. For instance, if there's increased airway resistance and you're looking at your scalar waveform, you can look at it from the pressure time waveform, pressure on the y-axis, time on the s-axis. You will see that there's increase between the peak pressure and the peak plateau, all right? And then you see a normal peak plateau. So you'll be able to tell from your waveforms. I can't continue now. Ladies and gentlemen, I think we should stop here today. Let me just take some questions. Yeah, so let me take some questions and some contributions from everyone. I'm stopping the recording so that we can talk freely.